I think that that was absolutely outstanding, and I just applaud Julie's for a kind of a well balanced talk. And you know, I think although you'll see some thoughts about how I feel about it, I think you'll be surprised at some of my conclusion slides at the end about how I feel about the whole transfixation versus true fusion and arthrodesis. So you'll see a lot of my opinions throughout the talk today, but you know, I'm just as Julie's alluded to. I mean, I have a broad approach to the SI joint, and again, I think my conclusion will really help explain that. So I appreciate SIMEG and the leadership allowing us to have this. So as I alluded to, you know, my disclosures are, these are kind of the guiding principles that I use in my practice every day in the SI joint clinic. I do have financial interests in this. That I designed an SI joint fusion system based upon orthopedic principles that I do in my practice every day as a general orthopedic trauma surgeon. And also I have a growing revision practice for SI joint fusions. And so I designed the system to really help counteract a lot of the reasons why we're revising these. So to be very clear, the opinions expressed in this talk are mine, do not represent Mayo Clinic as my employer. So we'll talk a little bit about fusion and surgery, how we assess outcomes, how we prevent failure with SI joint fusions, and then how do we really enhance the fusion of the SI joint. And this is exactly the same thing that Julie's just presented about. Look at the amount of articles that are coming out about the sacroiliac joint, starting off with the early 1900s up to where we are now with this year having 375 articles presented about SI joint issues. So just an exploding field of interest. So when we look at fusion and musculoskeletal surgery, it's really in orthopedic surgery, it's one of our foundational principles in every joint in the body, where we really employ these fusion principles of preparing that joint, getting rid of the cartilage, compressing that joint, and giving it stability. And really, you know, I had the advantage and somewhat of operating all over the body with fusion principles. And the way I learned these was in one of our Bibles of orthopedic surgery by Dr. Salter. If people heard Salter-Harris fractures, but this is one of our Bibles about how we do orthopedics. And you know, we look up bones and arthrodesis, and I put this area up here called keywords, and you don't have to read everything that I'm going to put out there, but the keywords keep coming up in all of these Bibles with orthopedic principles of bone to be fused by producing a bony union across it, or what we call arthrodesis. A lot of us, you know, have read Campbell's Orthopedics, for those of us that are orthopedic surgeons, and we look at, you know, how do we perform arthrodesis of joints? Well, the arthrodesis must be securely held together by internal fixation, and that is done with a lot of different implants. And then if adequate bone isn't available, use bone grafts, preferably autogenous bone grafts. Here we have Charnley, one of our grandfathers of orthopedic surgery, the first hip replacement done by Sir Charnley, and talked about compression ankle arthrodesis. And so some of you that heard me speak before, I can't say compression enough times when we talk about, you know, using the SI joint. And, you know, regardless of the technique used, general principles should be observed. Create broad surfaces, cancellous bone to cancellous bone, and then stabilize that arthrodesis with internal fixation. And what I think is critical at the bottom is it may be difficult in osteoporotic bone. Again, if we look at this article written by Sir John Charnley, he talks about, you know, compression, which is the elimination of all shearing strains across the joint of interest in this point. This talks about, you know, denuding that articular cartilage to make sure we're getting bleeding bone to bleeding bone. We want to add bone graft, autogenous bone graft. This can help increase the fusion rates. And again, this is reported in textbooks based upon literature. Fixation of arthrodeses require compression. In rheumatoid bone, it's hard. Adequate compression is possible, even in osteoporotic bone sometimes, but the amount of compression can be difficult. So really, as long as adequate fixation and compression are possible, I like this part. The specific type of device is really of secondary importance. when I was putting this together, this actually is last night as I was kind of putting the final things, I looked at every single book up on my bookshelf in my office where I am right now, and I couldn't find transfixion up there. And so I did a quick little PubMed Google search for it, and it's actually mentioned in the literature about like external fixator pins and holding things in alignment to provide stabilization. So transfixion is out there, but if you didn't get bony union in these articles, the pins would break. So we got kind of an interesting thing. So transfixion is indeed out there, just employed a little bit differently. So this is coming from the orthopedic surgeon perspective, the principles of fusion, which everybody should be familiar with if they're practicing orthopedics: joint preparation, compression, and then stability. If there's too much motion, you get a pseudoarthrosis. And I think a lot of us dread that word, pseudoarthrosis, especially those of us that can engage in some spine surgery. And then you get that halo effect, whether it's in the S1 pedicle screws or wherever else. Outcomes assessment. You know, when we look at outcomes assessment of every surgery that we do across the spine, wrist, hand, foot, ankle, knee, we look at fusion results, and that's been well published in the ankle and in the foot, two arguably challenging places to get fusion. And that is directly correlated with their outcomes. If we look at the spine, these people have pseudoarthroses and continued pain. Well, I think if they have continued pain and imaging evidence of a pseudoarthrosis, that is how we judge, you know, outcome. And what is the answer to that? Well, you know, that typically, you know, as I'll say in a second, you know, comes up with revision surgery. Pseudoarthroses are not unique again to the spine. We see them everywhere. Adult reconstruction, hand surgery, foot and ankle surgery. And if you look at the pseudoarthroses investigation, just like the other slide I said, it's growing. We're looking more and more at failure rates and how we judge that. And you can see that the element or the research into pseudoarthroses is growing and is significant. Here are some examples across the body, looking at ankles and feet and pseudoarthroses. And when we revise pseudoarthroses, it's tough. This is an example of us, you know, taking a medial femoral condyle graft to go ahead and repair a non-union of the forefoot with good success, but potentially not necessary should principles be followed. I do a lot of talk with trauma surgery, and one of my favorite slides that I talk about is evaluating what causes non-unions. And I have this term that we've written about called X-ray forensics. And I try and look at the X-ray and find out what happened. Why are we having continued pain? Why is there pseudoarthrosis? And I think if we look at SI joint failures that come into my clinic, and I think it's a whole nother talk for us to engage in some time, but what causes failures? Why are some people coming with persistent pain after what appears to be a well-done surgery, whether it's transfixion device or some other device? So really delve into these X-rays about what happened and why this patient is where they're at. If we look at the outcomes, patients come into your clinic and they're still having pain. They say, well, what's going on? Am I not fused? And if they're not fused and they still have pain and there's a non-union pseudoarthrosis, the answer is revision surgery to gain an arthrodesis. So our end game with everything else is solid arthrodesis. And, you know, another talk is fun to do. We should do this sometime about how we revise SI joints. And it's not that hard if you use kind of revision principles and you know, different implants and so on. So that's a great segue for us to maybe visit about someday. When I look at why implants fail across the body, to include the SI joint, there are factors about why they fail. Oftentimes they're modifiable factors. You know, is there too much motion? Is there not enough biology? Is the patient's environment not conducive to healing? Are they extremely osteoporotic or osteopenic, not allowing ingrowth of our implants, or something prohibitive to fusion? So I think one thing we can modify potentially is bone density in some of these patients. How do we prevent failure in these patients? Well, I think, you know, from my perspective, again, I just follow your principles that you do every day. Enhance the application of those principles. And what I think you should decorticate and provide maximum joint preparation, like I do for every other fusion we do in the body. Principle: compress that joint to get the compression and the surface is opposed, and then provide stability. And I think a lot of the implants out there do provide some stability, and you need that stability to be maintained until there's ingrowth or fusion across that joint, and provide that stability. So, I think this is in my practice, I like to bypass that ALR bone because I think that bone density with Hounsfield's units is definitely compromised compared to that bone of the body of the upper or lower sacral segment, or S1, S2. I compress it. I aggressively debride it beforehand. I provide autograft from a drill that's designed to bring in the autograft, and then I also extend that with some form of demineralized bone matrix to help create more of what I call a slurry that we inject into there to create that fusion mass. I don't try and get away with anything. I just simply adhere to the principles of joint prep, compression, autografting. And this is where I really want to compliment Julius in his talk. And looking at the data, other ways do work. He presented a great review of the iFuse and also some other implants out there that do provide good patient outcomes, improved ODIs, improved VAS scores. So sometimes they work. The unlevel playing field is a great talk because there may be some bias. If you look at the majority of level 1 studies out there and they look at the author line, everyone is written by the SI bone company or whatever company we're talking about. The authorship may be a little bit biased in that. Other ways work. I think it is dependent. Again, we all struggle sometimes with patient selection and who's the right candidate for this. Bone quality is key. I think osteopenia or osteoporosis does portend a poor result with ingrowth in some implants. Revision rates based upon the SI joint clinic at Mayo Clinic are real. And, we have an advantage, like some other centers out there, of being the place where people come when things aren't working. And so we get to see these revisions. And I feel, based on what I see at Mayo Clinic, that they may be underreported in some studies. But again, I only see what the numerator is. I don't always know what the denominator is for some of these. So I think that the revision rates are real and do deserve some attention. So the closing thoughts in the last couple slides is that in the US, I think there has been some moves by industry to monopolize our implants that are being used. And I think this stifles innovation. I think it's a travesty that some of us are not being allowed to use what we think is the best implant for some patients. And I hope that we can address that as a group. All of us know that the SI joint is complex. And I teach all my residents and fellows that the SI joint is truly kind of the magic joint in the body. And it's clear that we haven't figured out exactly what is going on with either referred pain, neural connections with radicular pain. Why do patients have burning radicular pain into their foot? That simply by transfixing or fusing the SI joint, that pain goes away. It doesn't make a lot of sense. So there's something to go on with referred pain. Is the joint capsule inflammatory cytokines hitting the perineal division of the sciatica as it traverses underneath? A lot of different things that we need to investigate. But it's tough with an unlevel playing field right now. So I think, if the playing field should be open, let us in the market and patient outcomes, determine about the best implants out there. Closing thoughts, my final slide, there's arthrodesis and transfixion camps. I think there's different sides of the track depending on where you lie, but I think there are other methods out there. And just as Julius concluded with, I think pick the one that suits you best, the one you're familiar with, and the one that's best for the patient. And we have a guiding principle at Mayo Clinic. It's like the needs of the patient are the only needs to be considered. And that's the way I practice medicine every day with my patients, and just try and choose what works best. So I think I'd like to close with a huge thank you to SIMEG for opening up the discussion to have a fun talk about what's out there and what our thoughts are. I'd like to thank Julius for his. We just met a couple weeks ago, and I think we're across the seas, good friends already, and it was a treat to visit with them. I thank Jeff Donner for his presidency putting this together, and then my mentors. And I see Dr. Stark on the line here, and it's fun. He was one of the guys that introduced me to SI joint pain as a young resident. And Dr. Pauly, I don't know if he's able to join us, but another one who really opened my eyes to the SI joint and the interplay between spine and hip and the SI joint. So with that, I'll close with my talk. And I just really appreciate the good conversation coming forward. So thank you.
Great. Thank you, Woody, and thank you, Julius. I think it's pretty clear as I look at the participants and just the number of years of experience and the dedication to trying to understand our patients' unusual buttock and leg pain and all these other variety of symptoms they have, and how we've collectively come together to kind of, I would say, blaze a trail. And it was a very difficult trail when you first mentioned sacroiliac joint as a potential source of pain as an orthopedic surgeon or neurosurgeon. That was not in a big crowd that you would get a lot of support or applause if you gave a presentation. So those are rough times, but I see a lot of us have stayed the course because we could see we could help our patients. And for all of us who were part of this, or couldn't make it, but are in our camp, I think that is probably the most important aspect of what we actually are doing today, is reaffirming this interest. And it is all about the patient, the science, and all the different technologies that are evolving. They're great. And one of the reasons this meeting was actually put together, and we didn't really get too much into that specific topic, was the JBJS article described the iFuse technique as an arthrodesis. And, some of us in orthopedics, as Dr. Cross kind of outlined very well, who read those texts and were brought up with that, go, wait a second, that's not really an arthrodesis based on the fact that you don't see bone bridging. So our question was, should we be classifying this differently, especially when we look at registries? And as we all know in orthopedics, and I'm sure you have this in neurosurgery, especially with arthroplasty, we've learned a lot over the years, and a lot of those failures are early. And some of those failures were not early, but they steadily increased over time and then became even more exponential, and which would lead to different types of implant surfaces, techniques. And a lot of that, unfortunately, is, surgeon, technician dependent. So what we hope to do with this conversation, I believe, is keep the conversation going so that we know over time what we're actually going to be offering our patients. And I don't want to take up too much time because there's a lot of very, knowledgeable, experienced surgeons out there, but I just want to reflect on what Julia said and quoted, that this is the responsibility of the physician, the clinician, to decide what to do for their patient. And I think Dr. Cross outlined that this is becoming less of what we can do in medicine in general, and it seems like we have less control. But presently, within the treatment of our sacroiliac patients, we're getting limited by what we believe is maybe strong influence by industry to control the type of devices and the type of treatment we offer to our patients. And I think that's worrisome. So I'd like to end there and say whatever works, works, but it has to work long term. And I think we all agree with that. And, orthopedic fusion principles and durability are a key issue that has to be considered.